So in this video, we are going to look at injuries to the major limbs of the lower limb, the major joints of the lower limb, focusing on the joint stability, the factors that cause instability, and neurovascular complications. The objectives remain the same as for our last talk on upper limb joints. So the first case is a 34-year-old female driver who was involved in a head-on collision and her knees hit the dashboard. Her hip is held flexed and internally rotated, and we can see the x-ray on the left. So again, you can pause the video, go through the questions on your left, and see if you can come up with some answers. So this, of course, is a posterior dislocation of the hip. The hip is a very highly protected and stable ball and socket joint, and of course, with increased stability comes decreased movement of the joint and decreased flexibility. The stability of this joint comes about because of its structure. This is a deep ball and socket joint which is well protected by very strong muscles and the bones of the pelvis. And apart from the bony acetabulum, this is extensively increased in size by the acetabular labrum, the cartilaginous part of the acetabulum. On top of this, the joint is held in place by strong ligaments, including the iliofemoral, ischiofemoral, and pubofemoral ligaments. And finally, all the strong muscles around the hip joint, the quadriceps femoris, the adductors, the hamstrings, and the gluteal muscles, contribute to the dynamic stability of the hip. The most common mechanism of injury is a backward force on the femur with the hip and knee flex. So in the sitting position, there's a force from in front through the knee, on the knee, through the femur into the hip, and this produces a posterior dislocation. Central dislocations are less common and they may be seen from a fall from a height, and the importance of these injuries is that they can cause serious intrapelvic injuries, or they can be associated with serious intrapelvic injuries. Dislocated hips are notoriously difficult to put back in place, and usually once they go back, they're fairly stable. But fractures of the acetabulum or femoral head, particularly unstable or comminuted fractures, can lead to instability. It should be pointed out that hip prostheses are generally less stable than normal hips and are more prone to dislocation. The big neurovascular complication of hip injuries is sciatic nerve injury, when the femur is displaced posteriorly. It presses on and stretches the sciatic nerve, which can cause significant sciatic nerve injury. The second case is a similar story of a driver in a head-on collision and his knee hits the dashboard, but in this case the knee is deformed and swollen. Pause the video, see if you can answer the questions asked. The knee joint is a highly unstable hinge joint. The bony articulations are very shallow, and the stability of the joint is really due to the ligaments. The anterior and posterior cruciates cross over in the intercondylar groove, the anterior cruciate going from the posterior part of the femur to the anterior tibial spine, and vice versa for the posterior cruciate. The anterior cruciate prevents excessive forward movement of the tibia on the femur or excessive hyperextension of the knee. The posterior cruciate prevents excessive posterior movement of the tibia on the femur. The medial and lateral collateral ligaments provide stability from varus and valgus strain. So the medial collateral prevents valgus deformity at the knee, and the lateral collateral prevents varus deformity. And the menisci act as cushions between the femoral condyles and the tibial condyles, or the tibial plateaus, and they may be injured with rotational injuries of the femur on the tibia. Dynamic stability is also provided by the flexors and extensors of the knee. And these strong muscles have an important part to play. When we're thinking about mechanism of injury, there are 3 injuries to consider: knee dislocation, which is rare, patellar dislocation, and ligamentous injuries. And we'll go into these a little bit more on the next slide. The less serious injuries are not usually associated with neurovascular complications, but tibiofemoral dislocation may be associated with injuries to the popliteal artery, posterior tibial nerve, or common peroneal nerve. So just to look at these injuries in a bit more detail. Knee dislocations are not very common. They're due to severe forces on the knee, and they're usually posterior or anterior. Because of the force applied and the amount of damage done, they are associated with compartment syndrome, injuries to the popliteal artery, or injuries to the posterior tibial or common peroneal nerves. Patellar dislocation is quite common. It's not usually due to a direct force on the knee, but due to a rotational injury, particularly external rotation of the tibia on the femur with the foot fixed. And it's seen in female athletes. It's really due to a unequal pull on the patella from the quadriceps with weakness of the vastus medialis. This is exaggerated if the patient has knock knees or valgus deformity, and if the knee has a shallow intercondylar groove. That just makes the patella easy to slip off the intercondylar groove as a lateral dislocation, and of course that would be exaggerated in patients with ligamentous laxity. Ligamentous injuries may occur with rotational hyperextension or varus or valgus strain, or anterior or posterior movement of the tibia on the femur. Rotational injuries may cause tears to the menisci or damage to the anterior or posterior cruciate ligaments. A varus strain, or strain from a force from the inside of the knee pushing it outward, can tear the lateral collateral ligament, whereas a force from the outside of the knee pushing it inward can tear the medial collateral ligament. Hyperextension injuries can tear the anterior cruciate ligament, and if you have a flex knee with the foot fixed and you're hit from behind pushing the tibia forward, that can lead to an anterior cruciate tear. Whereas if you have the same position with the knee fixed and get hit from in front, that can cause a posterior cruciate tear. Finally, a footballer twisting his ankle with the injury shown. Pause the video, see if he can answer the questions. The ankle is a highly stable hinge joint, and the stability is dictated by the bones. The tibia and fibula, through the lateral and medial malleoli, form a deep mortise into which fits the talar dome as a tenon. So the talar dome fits snugly into that groove formed by the lateral and medial malleoli. This is reinforced by ligaments on the lateral side, the anterior and posterior tibiofibular ligaments, and the calcaneofibular ligament as well. Medially, the strong deltoid ligament holds the talus in place in relation to the medial malleolus, and finally the tibiofibular syndesmosis keeps the mortise snug. Muscles provide dynamic stability. Ankle injuries tend to be weight-bearing injuries, usually with an inversion or eversion force, although rarely this may be due to axial loading, such as a fall from a height. And the instability is caused by disruption of the ligaments as shown below. There are no specific neurovascular complications, but compartment syndrome may be seen. So again, this was a quick look at injuries to lower limb joints. We looked at the anatomy, mechanisms of injury, and causes of instability, as well as neurovascular complications. I hope you enjoyed the talk. Thank you.